Muy buenas tardes, bienvenidos al Ateneo del mes de septiembre de la Universidad Javeriana. Es para mí un placer en esta tarde presentar al doctor Khorshid Mohammad. El doctor Khorshid Mohammad es miembro de Alberta Health Service en Calgary. Él es profesor de pediatría de la Universidad de Calgary y también es líder de neonatología en el Alberta Children's Hospital. Doctor Mohammad, como antecedentes, él se graduó en el 2006 en la Universidad de Damascus en Arabia y completó su entrenamiento o su fellowship de neonatología en Calgary en el año del 2010. También hizo un entrenamiento en neurología neonatal en la Universidad de British Columbia y pues también se entrenó en ecografía neonatal en British Columbia en el año del 2013. En el 2014, el doctor Khorshid Mohammad estableció el programa de neurocrítico junto con la Universidad de Calgary en colaboración con neurología pediátrica, y este programa es uno de los dos que existen en Canadá. El doctor Khorshid también fue fundador o es fundador del programa SCAN Program, que es un programa basado en ecografía neonatal. Y también el doctor Khorshid estableció el programa de monitoreo neonatal y tiene un centro de simulación, un laboratorio que incluye ecografía transfontanelar y también incluye lo que son simuladores y simuladores también para aprender lo que es resonancia magnética. El doctor Khorshid también es miembro fundador de la Sociedad Mundial de Neonatología. Así que para mí es un placer en esta tarde tenerlo como invitado especial de la Universidad Javeriana. Vale la pena recalcarles que la siguiente presentación va a ser en inglés y las preguntas que tengan al final, por favor, que nos las hagan llegar para poderlas hacer llegar al Dr. Khorshid. Dr. Khorshid, I was saying that for me it's a pleasure to introduce you this afternoon. I have the opportunity to meet Dr. Khorshid 5 years ago. So I am so excited to be here again. So Dr. Khorshid, you can start now.
Thanks, Dr. Guzman, for the nice introduction. It's really my pleasure to present back to the group. And thanks, Dr. Montelegre, for the invitation as well. Today, I'll be presenting on our Drive IVH to Zero project, the preterm brain injury prevention project. Looking back at this project, which lasted almost a decade, I tried to select 4 milestones leading to the interventions and 4 key interventions. I thought these milestones and intervention will be transferable to other centers and other institutions. I will talk about problem identification, why we chose IVH, not white matter injury, measures and definition. We'll talk about counseling the families versus benchmarking. We'll talk about risk factors versus protective factors, stakeholders versus frontline provider engagement. Are we looking for approval or execution? Then I would move to key interventions. I will try to present it in a chronological order, starting with the outreach program and golden hour, to deliver or not to deliver. That was our question. Then minimal handling versus nurturing moments, and the hemodynamic management. Should we go clinically versus echo-driven management? And finally, the respiratory management, to extubate or not to extubate. And that was the question we tried to answer. But before going there, I wanted to show you that the bundle works, because we always face lots of skepticism, and you will face that if you implement such bundle in your unit, because it's hard to believe that these simple interventions will make such huge impact. As I go through the bundle elements, you will see it's not rocket science. One of the visiting professors told me actually at the beginning of the project, and I'm quoting him, say, are you trying to convince me that you can reduce IVH by covering incubators and using pin lights? And quote. This was the first publication where we studied the impact of the bundle on the incidence of acute brain injury in infants born less than 29 weeks gestation age. We had 301 before the intervention and 364 after the intervention. They were all inborns. They were born at the tertiary center. Some of the practice changes because of the bundle are shown here. The use of inotropes and normal saline boluses was reduced significantly. The use of delayed cord clamping increased. The rate of pneumothorax and use of opioids were decreased significantly. The dark bars here are the incidence before the intervention, and the light gray are after the intervention. You can see that the rate of mortality reduced by more than 50%. The rate of composite of death and or severe brain injury was decreased more than 50%. The rate of severe brain injury was decreased by more than 50%. The rate of brain injury of any grade was decreased significantly, but not by 50%. The composite of mortality and or surgical post-hemorrhagic ventricular dilatation was decreased by more than 50%. And this is the graph showing the timeline where we started the intervention. You can see the sharp reduction in the incidence of composite of death or severe brain injury. Not only that, the fluctuation in the incident decreased, meaning there was more consistency of care. The new practice became the new norm, and that's the aim for any quality improvement intervention. We performed interrupted time series analysis, and the purpose of this kind of analysis to make sure that the changes that we are observing is due to the bundle, not the practice change over time. It was still significant after performing the interrupted time series analysis. What about the outborn infants? We know that outborn infants are at the risk of severe brain injury. In this paper, we looked at the impact of the neuroprotection bundle integrated into our outreach program on the incidence of acute brain injury in preterm infant born less than 33 weeks gestation age. Our center receives babies from half of the province of Alberta. In the table, you can see similarly that the acute brain injury of any grade was decreased significantly, moderate to severe post-hemorrhagic ventricular dilatation was decreased significantly, mortality and composite of death or severe brain injury. Similarly, we did interrupted time series analysis, and the intervention was significant, independent of the change of practice over time. Even with all this, there was still skepticism. The question we often faced was, how about the long-term outcomes? You can't prove that your bundle is working until you show us that the long-term outcome has improved. So in this paper, we studied the impact of the bundle on the long-term outcome. There was a significant reduction in the composite of death and or neurodevelopmental impairment after the implementation of the bundle. We adjusted for all kind of confounding factor, and again we performed interrupted time series analysis, and the bundle did improve the long-term neurodevelopmental outcome and decreased the incidence of cerebral palsy as well. Now, we also moved in the right direction compared to the rest of the country. These are funnel plots out from the Canadian neonatal network. The dots represent tertiary centers in Canada. The pink lines are the confidence intervals. The line in the middle is the odd of 1. So means if you have the odd of 1, you didn't increase the incidence, and neither you decrease the incidence. You want your center to be below the midline. Our center was in the middle of the pack. This is the Calgary Center. After the intervention, we were one of the lowest center in the country, and we maintained that for 3 years. Now, we are not the only one who showed the positive impact of the bundle. There have been several publications on the subject showing similar findings. I just picked few to illustrate that this bundle works with other groups. We also we looked at it in the resource limited settings. So we had few trips to the Latin America countries, Quito and Bogota. This is a picture was taken in Quito, Ecuador. And the group in Bogota, actually, they published a paper. Bogota and Quito, they adopted the bundle, and the Bogota group showed that the implementation of the bundle has significantly decreased the incidence of severe brain injury compared to the rest of Latin America countries from the EPIC Latino network. And this paper was published. So hopefully by now I presented to you sufficient evidence that such bundle works. I will now move to some milestones and key intervention. The first step for us was problem identification. Which type of brain injury should we target? How do we define and classify the brain injury? How to prevent it? Do we need to prevent this type of brain injury? What is the prevalence of it? If the prevalence is low, there's no point of going through all this painful exercise to decrease a problem when it's very low. So that's where we want to head. So should we look at the cumulative subtle white matter injury that shows on the left, or should we go with the acute early brain injury on the right? Prevention of white matter injury is very complex and requires time. To ensure feasibility, compliance, and quick results, we decided to go with the acute early brain injury prevention. In addition, we thought there is no point of preventing white matter injury when we have high incidence of reperfusion or acute brain injuries. In another word, you cannot run before you walk. The unique anatomy of a preterm brain put it at risk of having IVH. For example, the venous return, the medullary venous return, it goes through the germinal matrix. If you have hemorrhage in the germinal matrix without it popping and venting through the ventricles, the pressure will build up and it will tamponade out the venous return. If you tamponade out the venous return, there will be ischemia. And after ischemia come hemorrhage. And that's why we call it hemorrhagic infarct. And that's classic grade 4 IVH. Similarly, with the arterial system, the arterioles ends at the level of germinal matrix. So if we have ischemia, the first area that suffers is the germinal matrix. And ischemia is always followed by reperfusion. And at the micro level, premature babies, their blood-brain barrier is not complete yet, as compared to a robust blood-brain barrier where you have all these cells that protect the vessels. In a premature infant, the vessels or the arteries are almost naked in the densely populated area. So any fluctuation in your vital signs, whether it's blood pressure, aggressive interventions, CO2 fluctuations, might rupture these membranes and cause IVH. And one interesting fact about germinal matrix is that it covers most of the lateral ventricles. And as the gestational age becomes higher and higher, it retracts and finally it resides at the level of the head of the caudate. That's why we may get one of those posterior grade 1 IVH, and it could be mistaken for grade 4 IVH because of the location is not unusual. It is not located at the caudothalamic node. I'll show you one example later. Another terminology is ischemia. Ischemia is often the initial insult followed by reperfusion. As you all know, the fetus is exposed to hypoxic environment in utero, and the fetus can cope with it due to the abundance of fetal hemoglobin. Fetal hemoglobin has high affinity to oxygen. This allows the red blood cells to hold onto oxygens and not release it unless there is a hypoxic environment, and hence it breaks the cycle of hypoxia. So let's move the key intervention to, which is the outcome measures. How did we measure the preterm brain injury and how did we define it? If we use a wrong yardstick or inaccurate tool, we will misinterpret the results, which will create false reassurance. Let's say you think you don't have a high prevalence of severe IVH, but because of the way you are measuring it is wrong, the incidence is in fact high. Or on the other hand, your bundle has worked, but because of the way you are measuring your outcome, you think you have not reduced the risk of severe IVH. So you have to standardize. We have to standardize the way we classify and define the brain injury in preterm babies. So what is the best tool to measure our outcome of interest? Is it MRI versus ultrasound? The advantages of MRI is it's more accurate. and it's specific. It has better predictive value compared to ultrasound. On the other hand, ultrasound is readily available. It's mobile, it's easy to use, and can be done frequently and repeatedly to test interventions. We decided to use ultrasound as our outcome measures for all those reasons. Let me take a detour and present a case to you. This is a 23-weeker at birth female. Mom received only one rescue dose of steroids. She was born at our level 3 centers vaginally. She was intubated at birth and cord pH gas arterial was 7.19. Her admission temperature was lowish. She was 36.5. She had UVC and UEC in place. She got RDS, required surfactant. She failed extubation, and she had CO2 fluctuation and mixed respiratory and metabolic acidosis. Her head ultrasound report read as follows. She had grade 4 IVH on the left. She had blood in the ventricle. She had no ventriculomegaly. So the question, how would you counsel the family? What would you do with this information? Do we tell the family that the stats of 23 weekers with grade 4 IVH, or do we show them the images and explain the risks? And this dilemma highlights the importance of differentiating between benchmarking versus counseling the family when we use ultrasound as a tool. There's a big difference between those two. For example, these are all grade 4 IVH, and you can easily appreciate that this baby with this small grade 4 IVH, the outcome will be much better than this baby with extensive severe grade 4 IVH. Without looking at the images, just by reading the report, you read them all as grade 4 IVH. And we will counsel the families at 23 weeker with grade 4 IVH. They say this one, they have bad outcome. And sure, this is what we did. Our team approached the family, we read the report, and we talked to that mom about redirection of care and go to palliative care because this is 23 weeker, partial steroids, still ventilated, and has grade 4 IVH. Of course, this mom refused, and I'll show you the outcome of this baby later on. What we did to improve our ability to counsel the family, we created a smartphone application and made it available for free to encourage usage. This is free for anyone who wants to download it. You will be asked questions in sequential manner till you reach the final diagnosis. There are pop-up images at each stage to illustrate the terminology. Also, you can access the atlas of definitions by clicking on this button. We also created a library of abnormal studies representing sources of variation examples, then loaded them into simulators created locally. We use this simulator in Bogota when we run our workshop there, and integrated this into our training program. Our fellows are encouraged to look at the images before reading the report, and they have unlimited exposure to the phantoms and simulator. They can take it home and get trained on them. Now, a bit more on the classification and benchmarking. We agreed that if you want to counsel the family, look at the images. Don't say grade 1, grade 2, grade 4 IVH. Show them the image, see how big it is, put it in the context of the baby, and then counsel the family. But what if you want to test your intervention? You need to standardize the classification if the purpose is testing the interventions. Some of the source of variation that we identified locally and nationally, one of them was making the diagnosis based on the one cut. So this example is a 24-weeker who was ventilated, had large PDA, and had partial steroids, part of a twin. And day 4 cranial ultrasound showed this big clot. And by just looking at the coronal cut, the report was saying grade 4 IVH. And again, the team counseled the family about redirection of care. But when we looked at the sagittal, you can tell that the clot is confined in the codothalamic notch and it's outside the parenchyma. This is in fact not grade 4 IVH. This is grade 2 because there is some blood lying at the back of the occipital horn. So we call this grade 2 IVH. So that's one source of variability. Always confirm it with 2 planes before making the final diagnosis. The other is echogenicity. How much brightness is too much and what is normal? We decided to take the choroid plexus brightness as reference. If the echogenicity is brighter than the choroid plexus, we will call it significant. If it is less, we will just follow it up. This was an example of baby came with seizure that showed this area of echogenicity. It was reported as intraparenchymal hemorrhage, but when we did the MRI on the second day, it showed that this was just an edema. And the third source of variation was grade 2 versus grade 3. When do you call something grade 3? A classic Papil classification says that the blood has to fill more than 50% of the ventricles and the blood should distend the ventricles. But 50% of what ventricles? 50% of normal sized ventricles or 50% of enlarged ventricles? And also, if I had a grade 2 IVH like this case, where the blood clearly is not filling more than 50% of the ventricles and it's not distending the ventricles, but what if I repeated the ultrasound and I saw these images? Would I call it post-hemorrhagic ventricular dilatation as a complication of grade 2, or would I upgrade the grade and call it grade 3 right now? So that was another source of variation. The variation is reality whether you look at among the centers in the country. So this was a study in Canada. We looked through the centers and you can appreciate the variability in the incidence of preterm brain injury. Or if you compare countries, these are countries participating in the INEO network, and you find the variability in the incidence of preterm brain injury among countries. Locally was the same story. Part of this is due to the variability in the way we are defining the preterm brain injury. So we put together a task force of radiologists, neuroradiologists, and neonatologists across the country, and we put together a consensus statement on preterm brain injury classification, and we publish it. Implementation of this classification locally in our center has decreased the variability among us as neonatologists and in the reports as well. We are looking at testing this classification predictability on the long-term outcome of the long-term outcome. Step 4, identifying our own risk factors. Your risk factors may be different from our centers and ours might be different from yours. So what risk factors and what protective factors we have when it comes to preterm brain injury prevention? For us, we grouped the risk factor in teams and broken them down into modifiable risk factors in preparation for developing our intervention following the 80-20 rule. So 80% of your desired outcomes comes from 20% of your interventions or risk factors. So we try to look for key interventions. If we change them, 80% of the desired outcome will happen. So we had a hemodynamic risk factor, ventilation risk factors, outborns, handling, infections, PDA and PPHN versus RDS, and all leads to brain injury here. One good news is by auditing and identifying risk factors systematically, the incidence of brain injury will decrease without any intervention. This is due to the fact that we all slow down when we realize somebody is watching, like when you drive past a cop. It's just our human nature. The final step before moving to key intervention is engaging our team. There are two kinds of members you need their engagement. One, you need their approval. Those are stakeholders. And the other type of members, you need their buy-in. Those are the frontline providers. They are the ones who will execute your plan. We involve stakeholders during the development stage. For example, the Respiratory Care Committee co-authored the respiratory section of the bundle. Same goes to the hemodynamic group, infection disease prevention committee, and so on. When it came to execution, we thought of two groups to engage, nurses and respiratory therapists. One fact about nurses, if you convince them that your project or intervention is good for a baby, they will take it to their heart and they will guard your intervention with their lives. And that was lots of complaints we got of nurses not allowing the physician to touch their babies and examine their babies anymore. And there are steps between the finishing your plan and starting the intervention. And that's to put an ambitious goal to build momentum. We set a goal to decrease the severe brain injury by 50% from our baseline of 12% in a year. And many have discouraged us and advised that we are setting ourselves to failure, but that only fueled our desire to achieve our goal. Now, speaking about interventions, we spread our risk factors that we identified over time to look for windows of opportunity to intervene. So we start with the outreach and golden hour intervention. We gathered our team and visited personally all referring centers to deliver didactic, simulation, and case discussion sessions followed by telemedicine. We advocated for in utero transfer. Many of cases ended up delivered outside the tertiary center could probably have been transferred in utero. We encouraged the use of antenatal steroids and magnesium sulfate. We developed a neuroprotection bundle on transportation, which was incorporated into our outreach program, which included interventions like decreasing vibration, noise, and handling on transportation. Now, the golden hour approach, it is a stepwise approach to thermal regulation to prevent hypothermia and also optimizing respiratory support through the early CPAP application and FRC, functional residual capacity establishment, and early caffeine initiation. Timely vascular access, our practice has been now in tiny babies to insert PIV and start dextrose while securing the central lines to avoid hypoglycemia, and also early TPN and nutrition and minimal handling. Minimal handling, we had to come up with a window of intervention. So you can't leave it loose. You have to come up with a timeline. This window had to be as short as possible to avoid fatigue. If it was long, people will get fatigue of your intervention. They will get bored. At the same time, it has to be long enough to capture our intervention and to make the desired impact. We came up with the first 72 hours critical window, given the fact that vast majority of the early acute brain injury occurs in the first 72 hours, as well as most interventions and many complications. We put up signs of sleeping brain and clock to remind bedside staff about critical window. Some of the recommendation was not to check red reflexes on admission, no length measurement, no forelimb PP, and to bundle the physical examination so everybody is examining the baby at the same time, not the nurses, then the RTs, then the trainees, then the staff neonatologists. We asked them all to come at the same time and examine the baby at the same time. We also advocated for midline head position, which in itself may not prevent IVH, but it served as a reminder of the minimal handling window for the team. The third and one of the most impactful intervention, in my opinion, was the hemodynamic management. As you know, preterm infant autoregulation curve is almost flat and it's shifted to the left, meaning the lower the blood pressure, the lower the blood to the flow to the brain and vice versa. And also preterm babies who ended up developing IVH, they had lower number of epithelial progenitor cells. These are the building blocks of vessels. So babies who had IVH had significantly less building blocks of vessels, and there was a dose effect. So the worse the IVH, the lower the APCs in this baby. They are prone to ischemia. With the pressure passive autoregulation, then after ischemia, reperfusion will happen and they will have IVH. In this paper, we studied the association between the early inotropes use and brain injury in extremely premature infants from the IVH prevention cohort. We studied 497 and we used our classification of preterm brain injury. We defined inotropes use as any use of dopamine or dobutamine or hydrocortisone in the first 72 hours of life. And there was clear association between the use of inotropes and all kind of mortality and morbidity. We adjusted for all kind of compounding factors, and this relationship held true. Based on this data, we protocolized our hemodynamic management by promoting the natural cord clamping or delayed cord clamping, we stopped screening extremely premature babies by echocardiography if they are clinically stable. This was an attempt to prevent treating numbers in otherwise stable baby. We also advocated to treat only after ruling out iatrogenic causes such as pneumothorax. If the baby is hypotensive, we need to do an X-ray, make sure that the heart's not squeezed because of the pneumothorax or hyperinflation due to the ventilation. We added clinical marker to the blood pressure measurements. So basically, if the mean BP was below the gestational age and there were one or more clinical markers such as prolonged capillary refill time, high lactate or decreased urine output, then a bedside cardiac echo was recommended at that stage to direct our management. For example, if the heart is empty, our management will be to give fluid. If the heart is contractility is poor, then the management will be giving certain inotropes such as dobutamine or epinephrine. If the PDA is there and it's large, then the management will be a combination of low dose of dopamine and treating the PDA itself if the blood pressure is low. Now, we started the delayed cord clamping campaign. When a baby breathes, the pulmonary vasculature bed opens. And if the cord is connected, then it will take the blood from the cord and the placenta because they have low pressure. On the other hand, if the cord is cut immediately, then that initiation of the breath will take blood from other organs through the PDA, which will cause ischemia followed by reperfusion. And cord milking make me a bit nervous as it can change hemodynamics very abruptly and may cause harm. There are some studies showing that. It's interesting that historically immediate cord clamping was based on no evidence and the assumption that the cord is dirty. And yet it took us many RCTs to prove what is common sense in nature. This is a short video I want to show you. I hope it will work. Doesn't work. Anyway, this is a video showing a primate giving birth, and this primate is resuscitating her baby on an intact cord, doing suction and clearing the airway, and then both of them are happy while the cord is still intact. So this is common sense in nature that even the other animals and mammals they do and they know about.
Here it comes.
Oh, I think
Here it comes. This is it. That's the head. That's it. It's out. It's out. That's it.
She's starting to remove the amniotic sac.
Whoa, there we go. Yes.
Wow, she's just cleared the baby's airways. He's reacting to his daughter's birth. First sound. This is amazing. It's incredible.
Now, in this paper, we presented the result of protocolization of the hemodynamic management. We were able to reduce the use of inotropes significantly to the point it is extremely rare to use any inotropes in our unit in the first 72 hours of life in extremely premature infants. It also showed that there was a significant reduction in the reperfusion brain injury, that is IVH, without an increase in the ischemic injury, which is cystic PVL. That is the balancing measure. If you are not treating lots of low blood pressure, there is a risk of increasing the ischemic type of injury because of the low perfusion. We did not find that in our study. What about the dilemma of PDA, diagnosis and management? We looked at the PDA story through our IVH prevention cohort. We had 258 cases with available echo or targeted neonatal echocardiography. We found that babies with no IVH, their PDAs were less likely to be treated medically. So basically, they weren't significant enough for the provider to decide to treat them. On the other hand, we saw no differences in the IVH based on the echo findings. So if we are treating just numbers, those numbers in our cohort, at least in our study, we didn't find a good correlation between the echo numbers and the IVH. So this brings up the question of prophylactic versus targeted indomethacin treatment. Indomethacin is falling out of favor due to the risk of spontaneous intestinal perforation and the exaggeration of persistent pulmonary hypertension. This is a nice study led by one of our colleagues in Edmonton, where we looked at the use of prophylactic indomethacin at different gestational ages and the risk of spontaneous intestinal perforation and severe brain injury in the Canadian neonatal network participating centers. Interestingly, we found a cutoff at 26-week gestational age. Below that, if you give prophylactic indomethacin, you in fact decrease the risk of both brain injury and spontaneous bowel perforation. After 26 weeks, you lose the protection against brain injury. At the same time, you increase the risk of spontaneous bowel perforation. So that's why we picked 26 weeker as our cutoff. Below 26 weeker with some risk factors, they will be eligible for prophylactic indomethacin treatment. My personal approach has been, if I had a baby who is ventilated and has RDS, required surfactant with partial steroids, I do echocardiography at around 24 hours. And if I see such PDA, these are just to orientate you. If the blood's flowing away from the probe, this is the probe, it's colored as blue. And if it's moving towards the probe, the color will be red. You can see blue and red at the same time. So the blood that's flowing through the PDA is bidirectional. And you confirm that with Doppler. Above the baseline is left to right, below the baseline is right to left. So there is bidirectional PDA. I treat this PDA at this stage when it's mostly left to right with some right to left because there is no ischemia yet. Once it becomes completely left right, at that stage it will steal blood from the brain and may cause ischemia. I treat these babies with indomethacin every day. I follow up and I do echo and I stop endo once the PDA is closed. I don't complete the course. This is not to say this is the right approach or not. This is just my approach. Finally, the respiratory management. So the question we had was whether to extubate or not. So our aim was to decrease hypercapnia and extubation failure. Therefore, we advocated to keep these babies below 26 gestational age intubated for the first 72 hours of life while working on our intubation and extubation protocol. We then studied the impact of hyper and hypocapnia on brain injury. To our surprise, metabolic acidosis was the most important factor more than the hyper and hypocapnia. And we saw that there was a dose effect. You see, if the lower the bicarbonate, the babies with grade 4 IVH, they had lower the bicarbonate, they had higher mean lactate, they had lower mean pH. And going back to physiology, it made sense as CO2 doesn't cross the blood-brain barrier. It has to be converted to hydrogen ion. That's why acidosis is more harmful and it's worse with hypercapnia. The worst combination is having respiratory and metabolic acidosis. Are we causing harm by keeping these infants intubated to avoid variability? This is a CIHR grant we got to address some of those questions related to ventilation and brain injury, and these are some of the questions we were hoping to address. We started with the last one through a comparative effectiveness trial design. Now, apart from all this intervention, if you are a person who wants to take on this personally, there are few books that I have read and I would recommend if you want to lead such project. These are some of the books that I have read and I found them very helpful in this regard. And one last thing I will advise outside the traditional evidence-based research is to find a way to make this personal, to keep you motivated, to feel the drive to zero every day. I personalized my license plate. In Alberta, you have only 7 digits, so you have to be creative. You have to read drive, and then you come back IVH to 0. And then one of my the fellows read, they say, hi, you are Dr. IVH. So now they are calling me Dr. IVH. And we have to keep our eyes on the ball. Otherwise, culture will eat strategy for breakfast. In our center, we let our guards down and the rate of IVH bounced back to the baseline before the bundle. We revamped the bundle implementation and we improved our outcomes again. Now, what if despite all the bundle and the intervention, you still have a baby with grade 4 IVH, at least on the report, or post-hemorrhagic ventricular dilatation, or you have a baby with grade 4 IVH with porencephalic cyst later on? Would you give up and say, I did my due diligence, we implemented the bundle and we can't do anything about it? Or there are other interventions even after the preterm brain injury? Now, a couple of things we have been working on. One was the post-hemorrhagic ventricular dilatation. There are two groups when it comes to this. There are the neurosurgeons, when they usually tend to intervene late, and there are neonatologists with the Elvis trial and Netherlands group where we are very aggressive in the intervention. Where the truth lies in somewhere in between. So we have to come together to the table and find a common ground between us. We, in our center, we got the neurosurgery and neonatology working together to put a protocol at, to standardize the time of the reservoir insertion. Now, after inserting the reservoir, the problem that we faced, who will do the tapping and who will do the measurements? Because these babies need daily head ultrasound and they need daily tapping, and sometimes you do it twice a day. If you leave it up to physician, we are too busy. These reservoirs tend to be not tapped frequently and the pressure built up, and then some of them leaked the CSF around the reservoir and they had meningitis and worse pus inside the ventricle. We went back and we trained our nurses to perform cranial ultrasound at the bedside for the purpose of measuring the ventricles only. So we asked them just to do one cut at the level of foramen Monroe and do the measurement, then send us the images. They will send us the images and then we'll tell them this baby needs tapping or not. And then the nurses will perform the tapping. By doing that, we made sure that this daily ultrasound is feasible, and also there is a consistency in daily tapping. And the third and the most important, because nurses tend to be more meticulous than physicians in general when it comes to cleaning, the rate of infection was 0 in the cases that we have tried the nurses to do the tapping despite multiple reservoir tapping daily. And if you have grade 4 IVH without ventriculomegaly, you don't need to intervene, but yet they are at risk of having adverse neurodevelopmental outcome. There are neuroplasticity intervention, stimulating the vision, stimulating the scent, encouraging the babies to have mom's scent and smell. So we have a project where if mom can't come to the bedside, we give her a tissue fabric. She will rub it against her skin. Then we'll bring it to the incubator so the baby can smell mom's, and that stimulates the baby's brain. Also hearing the mother's voice, father's voice, reading, music is also television. Taste. If you bring mom's own milk, they can taste it and they recognize the taste. Touch, the kangaroo care, the rubbing, the touching, all those are the intervention that you can do. It improves the brain plasticity and improves the outcome. This is the outcome of that 24-weekers with quote-unquote grade 4 IVH. They are 5 years old now. They are doing fantastic. You cannot tell which one of them had the brain injury and which one of them had normal brain. They are both doing equally good. And that's thanks to all the neuroplasticity intervention that their parents were doing. This was the 23-weeker with grade 4 IVH that we approached the family and offered them palliative care. And the mom refused. I wanted to show you the video that she shared with me. See if it will play. No, it didn't play. Anyway, so that didn't play. Thank you very much. I'll be happy to take any questions.
Khorshid, for this really good presentation. I have a question. Do you consider important the training of our neonatologists and fellows in brain ultrasonography, and what are the tools you consider we need to this kind of training in our country?
Yeah, and thanks for the question. I think it's very important. One of the outcome of learning how to perform ultrasound, we tend to look at the images more, and that's the key skill that I think it's important to have from learning how to perform cranial ultrasound, because now we are looking at the images and counseling the families based on the images, not based on the report. It's similar to chest and abdominal X-ray. We almost never read the report. We always look at the X-ray and counsel the family and make decision based on the looking at the images. And the head ultrasound shouldn't be any different. What resources you really need? There are online modules. I know the one that we have, Dr. Carlos Fajardo, has translated into Spanish, so those are available for free. Once you finish the online module, then you can go through some of the training through simulation and through the hands-on. It's not difficult skill to acquire. It needs maintenance. If you, once you know how to do it, if you are not practicing on actual babies, or if you are not forcing yourself to review the images every week and every few days, then the skill, you will forget the skills. I think to answer your question, it is important, and it's not difficult to establish such training program.
Dr. Khorshid, I heard you about skin to skin contact. I don't know if you have the knowledge about kangaroo mother care method. In Bogota, Colombia, a kangaroo mother care method was born. Do you practice kangaroo mother care method?
Yes, absolutely. And I want to show you this image. Can you see it?
Now not, but you can share.
Yeah, I shared my screen. So here is we have something called kangaroo thon. We put a kangaroo costume to encourage the skin to skin and kangaroo care. And in fact, now even babies who are cooled, the HIE babies, we allow the parents to hold their babies during cooling. They can hold their babies while cooling. It's extremely important to have the kangaroo care. It's extremely important to have skin to skin. Even if the baby is ventilated and you think it's too fragile to come out of the incubator because of the central lines and because of the tube, we can encourage the parents to put their hands inside the incubator to rub their babies and do the skin to skin, because we all know that each time you rub the skin, each time you do tactile stimulation, there are hormones that growth hormones to the brain that promote the brain growth and brain plasticity. And there are plenty of studies that shows the vital signs are better with the kangaroo care. In fact, there was that study that they had to terminate early because the kangaroo care significantly decreased the incidence of mortality, and it was not the ethical anymore to continue with the study without kangaroo care.
You think we think that kangaroo mother care method is like a surfactant for the brain, and we promote.
That's a very good analogy. That's right.
Yeah. And another question: we don't have indomethacin now in our country. Do you know another pharmacological therapy that you use to prevent intraventricular hemorrhage in infants less than 26 weeks of gestational age? Another?
Yeah, there was a recent study showed that ibuprofen is also promising if you give it early. The only thing with ibuprofen and indomethacin, it might worsen your PPHN. That's the only. But they showed that ibuprofen, and I would say if we implement all those simple approaches and intervention on transportation, decreasing the vibration and noise and whatnot, and all the neuroprotection bundle simple interventions, the need for indomethacin decreases significantly. Even in our center, despite we have the the protocol in place and we have the babies below 26 weeks are eligible, the use of prophylactic endo is very low because the bundle itself can decrease the preterm brain injury, incidence. And you guys in Bogota, you showed that. It's a beautiful paper showing that just by implementing in the bundle, you were able to decrease the incidence of IVH.
Another question. How many times during the day should premature baby be manipulated? What do you think about it? And how many hours of neuroprotection with sulfate magnesium is enough?
Well, it depends, I would say. There are what we found when we started this intervention, that we deprived the babies from nurturing moments. Let's say because we are so protective, we were worried about the interventions, we isolated the baby. There are some interventions which are good, like for example, going and touching the baby and talking to the baby and stimulating them. Those are nurturing moments, we call them, especially from the parents. There's no set time or limit. We try to bundle our interventions. Say you want to feed the baby at the time that the nurse is feeding the baby, the physician will go and assist the baby, and so on. So as long as you try to bundle those interventions, it will depend how sick the baby is, how much intervention each baby requires. But there are nurturing moments that we need to promote. Those are music, tactile stimulation, etc. They need more of those.
And the other question is how many hours of neuroprotection with sulfate magnesium is enough? It's about
Well,
the number of hours.
yeah, so it's been given for moms before delivery, basically. So if a mom comes at threatened preterm labor, you think that they will deliver, they give them magnesium sulfate. After delivery, there's no evidence that it works in preterm babies, but it's neuroprotection given to pregnant women at risk of threatened labor.
And what do you think about using plasma if thromboplastin time is increasing? Only with the laboratory.
Yeah, I must say, very rarely I used FFP early in the first 72 hours in preterm infant. We don't routinely do PTT and INR in premature baby if there is no obvious reason for bleeding. That also thrombocytopenia is the same thing. There is no clear cut of when you need to transfuse platelet. And in fact, there are some studies now cautioning against transfusing babies' platelets because it can worsen their immune reaction to those platelets. But we don't do PTT-INR routinely, and if there is a reason for you to do PTT-INR, the baby has DIC or clinically sick, then I would treat based on if they have prolonged PT.
Thank you, doctor. So, do we have another question? Okay, that's all. Thank you so much, Dr. Khorshid, for us. It was a good conference to improve our quality of care in the preterm babies. And we want to see you again. Thank you so much. Thank you, Veronica.
Thank you so much, Dr. Khorshid, for your kind collaboration with all Latin American babies, like always.
Thank you
I
very
hope
much.
to
It's
see
my
you soon.
pleasure. See you guys soon. Thank you so much. Have a nice
Thank
day,
you.
everyone. Bye.
Bye.
Thank you so much.